a left primary surgery for otosclerosis, so it's a case of Stapes surgery, classical one. But the thing is interesting, difficult case because of this very narrow canal that we have, and as you can see, a very close relationship between the facial nerve, which is covered by bone, and the superstructure, which is there. So this is the left ear, 12 o'clock, 3 o'clock, 6 o'clock, and 9. You can see the chord tympani, which is pretty thick, and the round window knee is the promontory here. All right, so first, of course, I would start by the introduced stapel joint separation. Allez, désarticulation. So I will use now a joint knife with a suction tube on my left hand, because I like to use the suction tube to stabilize the incus when I'm doing this. So I'm just elevating a little bit the incus to find the position of the location of the joint. There is kind of ossification here, which sometimes happens, so we need to do it very gently to avoid any luxation, dislocation of the stapes. And now I can check first malleus incus mobility, so I'm moving the malleus. And you see that the incus is fine, but still a little bit reduced in movement. I'm sure it's related to the connection with the stapes, so we'll check it again after that. So now you see the severe fixation of the stapes. We have this white dot here posterior to the posterior crus, which means that probably we have a otosclerotic focus running all along the entire stapes full plate. So I'm cutting now the stapes tendon, and now we're going to drill out the posterior crus. Trois de Chouc d'abord. I need to check everything, so I just want to remove this fibrous tissue here, which is between the facial nerve and the posterior crus. And now I should be able to drill out now the posterior crus. And because I cannot drill out at the distal tip of the posterior crus because it's too close to the facial nerve, so the diamond dust could not go within such a small gap. So I will have to drill out from this level, at this level, I think. All right, so again, I'm using now the suction tube to stabilize the incus, pushing a little bit the incus down to stabilize the stapes also during the drilling out procedure, and leaving the diamond dust doing the job by itself. It takes some time because it's a kind of a very thick posterior crus. There we go, posterior crus is cut. And now we need to drill out the anterior crus, which is a little bit more tricky. So I changed the position of my speculum, and I will try to reach the anterior crus. La fraise, s'il vous plaît. Okay, I think we can be able to drill out from here. And again, I cannot go directly to the distal tip of the anterior crus because for the same reason, it's very, very narrow. So I do it like a thinning procedure, and I try to reach the anterior crus. I think this is the anterior crus. It's nearly drilled out. Okay, I think it's done. So now we can remove the superstructure, Trois de Chouc, and now we should have access to the full plate. Of course, as soon as we have removed the superstructure, the the exposure of the full plate will be better. And now I will check again the mobility of malleus incus. So it's pretty narrow still, so we'll probably have to drill out the promontory a little bit. Calmez, s'il vous plaît. So you can see the facial nerve on the right, and I'm going to try to, if you see that if I move the malleus, the incus is moving well. So there's no problem with that, so for sure. And again, it's interesting to see that it's always better to check again after having removed the superstructure, because it helps. Now, we have this full plate, which I need to reach, mesureur. Now I need to measure the distance from incus to foot plate. So I'm going to use this Stapes measuring rod touching the full plate, and you see again this is close to 4.5. The upper one is in front of the incus. You see, I'm going to show you again. I'm touching the full plate, and the upper one is in front of the incus, which means 4.5. Okay, so the problem here, again, I cannot go directly to the full plate because it's too narrow. So I will have to drill out a little bit the promontory to have a better access to the full plate before performing the fenestra. La fraise. One of the problems that we have in this case is that there is a usually higher bleeding time with the drilling out procedure of the promontory. But I don't need to drill out too much. So of course I need to take care of the facial nerve on my right, but also of the incus, because if you do it too strongly, then there is a risk of dislocating the incus. All I want is to have a better access and safe access to the full plate before performing the fenestra. Okay, it's much better now. You see I have a better access, so I think I shall be able to do it. We have a little bit of a stapedial artery here. So what I will do, I will cut it because with the drill I think it will drill out. It will bleed. So I think I prefer to bleed it, to have the bleeding right now, to control the bleeding before starting the fenestra. 3 de chouk. 4,50 c'était, hein? 4,50. Le piston à 4,50. 3 de chouk. Okay, so you see here this very small stapedial artery. When it's a big one, you cannot do it, of course. But with this type of stapedial artery, we can definitely. And I prefer to wait a little bit, s'il vous plaît, before reaching the full plate. It's a pretty difficult case, but interesting to show. And you see we have now a better view of the full plate. So it should be better now and possible to perform the fenestra in a safe way. Okay, la fraise. You see all this tissue running over the promontory, which is bleeding as usual. Okay, so I go now to the full plate, perpendicular to the promontory, reaching the full plate in this way, and leaving the diamond thus doing the job. Quite a resistant full plate again. It's interesting to see that. So I'm doing very gently. You can see there's a progressive drilling out procedure, so the fenestra is not performed immediately. I do it very gently, taking my time to do it. You see progression of it's a progressive drilling out. The deepness of the full plate is decreasing step by step. It's nearly done. We have the fenestra already, but it needs to be enlarged a little bit. There we go. You can see the fluid coming up like this, which means in that case you can be sure that the fenestra is done. And you see here what we have, a nice fenestra. So I will, if I move the microscope, you can see the fenestra more, and I'm going to cover it with the vein graft. So I'm going to take the vein now. I think I need to press it anyway, because I took a nice one, but it's going to be too big and too thick. So I will put it on the saline solution because I thought I would need to press it. So I will do it now. Pince s'il vous plaît. Pince normale, voilà. I'll take this one. Okay. Okay. La presse s'il vous plaît. Mettez-la là. All right. scanner. You see, it's too thick for the case, so sometimes I like to press it to make it really thin. So, not always, but in this case, definitely it is better. Un 7 encore, s'il vous plaît, pour l'instant. Un 7 encore. So I just need to control the position of the bleeding, I think, but which is good now. You see, there is no more bleeding or a very small amount of blood, which is good enough for me. And I use the 0.7 sucker here, close to the fenestra, because I don't want to suck directly into the labyrinth. You know that. So I'm going to cover now the vein with the vein. Oui, donnez-moi ça d'abord. Allez, history. You see, it's much better now. It's more translucent, which means that the vein is better. Okay, so I'm going to use this part of the vein, which it would be good enough. I'll bring it with the sucker. This is the intima of the vein. So I know where the fenestra is, so there's no problem with to find it out with the piston already after that, because it's covered by, of course, fibrous tissue, but also now the vein graft and some blood, but you know where it is, so it's fine. So I'm just moving introducing the vein with the sucker and stretching it already with the needle from here. Even after having, press it, it's still quite thick, and you can see that. So it's important to take time to be sure that it's going to be in the right position like this, which I think is good. So I don't need to push it too far. I'm going to push it also with the prosthesis itself. So I'm going to cut it now with the cutting block. So 4.5. So I'm going to use a 4.5 hole through this cutting block. There we go, and I'm going to cut the shaft now, which is, as you know, 0.4 millimeter diameter Teflon shaft. And now I'm going to open up and break the memory of the loop of the piston. You use the needle here through the loop, breaking the memory, opening up the loop, forcing the opening. Okay, fine. So I'm going to introduce now with the sucker, trying to insert the distal tip of the shaft within the fenestra, which is not going to be very easy here. So everything is very small and very narrow. So we have to remember where the fenestra is. So then once we know that, we will try to place the shaft first directly to this position here, which is there, and you see it works. So let me see now if I can hold the loop with my left hand and introduce the loop around the incus. We've got this chorda tympani, so of course I don't want to crimp the chorda tympani. There we go. I think we have a nice position now. You can already check the bending side, which is there, which is working fine. Alright, so we have this chorda tympani right here. So this is not good. And again, I don't want to crimp the chorda tympani at the same time. So now I can crimp the loop with the two hooks, and again, if I use in this case a curved forceps, there is no big enough gap for leave room for the curved forceps. You see that the distance between the malleus and the incus is pretty narrow, pretty short. And the incus is pretty thick. I just want to be sure that the corda is right in the middle. So I need to remove the loop and place it again. And s'il vous plaît, because I think it's right into the trois de Choukouk. Yeah, definitely it's in the middle of the loop, so I cannot leave it like this. So we need to remove it and probably place the loop on the other side of the cord tympani. I'm going to try that. Like this. And now it's much better and much safer for the corda. It's quite a big corda, in fact, quite a thick one. Holding the loop with my left hook and closing it with the right one. Okay, fine. So you see it's very accurate. And now I'm going to insert, s'il vous plaît, et canneler. So we need to check the position of the shaft. Canneler. So you see the vein is covering everything, including part of a promontory and part of the fallopian canal, and looking for the bending side. Look, at least a nice bending side. If the prosthesis was not into the fenestra, then when you do this, you have you can see the shaft moving completely away from the other window, and so you have to change and put it in a different position. And again, the movement from the malleus, we can check it again, but it was working fine, so there's no doubt about that. The malleus is there, and you see it's working fine. Okay, so fine. I'm going to now reposition the tympanomeatal flap. C'était un combien de speculum? Un 5 encore, c'est ça? It was only a 5 millimeter diameter speculum, which is very, very narrow. So I need to train now the merocell. Merocell, s'il vous plaît. Oui, s'il vous plaît. It's too thick, so I'm going to divide the merocell and put the merocell now within the fenestra, within the canal. I mean, not the fenestra. Allez-y. Merci. Okay. Two interesting cases, which was common. Both were pretty close together. Same day. It's interesting to see that narrow canal. And the second one was also with a very narrow over window niche. So thanks very much for watching, and hope to see you again soon. Bye bye.